Ladies and gentlemen, distinguished guests, it's a great pleasure for me to be here with you today by video conference. I apologize for not being able to be there with you in person, but overlapping, conflicting schedules have made it impossible for me to leave Washington at this time. And so I appreciate the opportunity that Ambassador Birx has given me to address you briefly on this very important subject. As you can see from the first slide, my title is to deliver a sustainable AIDS-free generation. And I'm going to talk to you about the public health implementation that is based on the scientific advances that we here at the NIH and at other institutions have had the opportunity to provide as the framework and the basis for the implementation that has had such an important impact in its delivery by PEPFAR. But before I get started, I want to first thank Dr. Eric Goosby, who I worked with for so many years and who had such a productive tenure as Ambassador at Large in charge of the PEPFAR program, and to welcome my dear friend, Dr. Deborah Birx, Ambassador Birx, who I have been working with literally for decades, from well before the HIV/AIDS pandemic began until essentially the present time when we've continued our collaboration over these many years. Now, you all know the current status of the global HIV/AIDS pandemic, but I want to just bring it up to put it into perspective about the impact of the PEPFAR program based on the fundamental, basic, and clinical science. The numbers are familiar with you. You see there are 70 million total infections globally over the period of time that has been measured, 36 million total deaths from HIV, with 36 million people living with infection. And as to the last recorded year, proof that the epidemic still rages, with 1.6 million deaths and 2.3 million new infections in 2012. As we all know, this is predominantly an infection and a disease and a pandemic of the developing world, with more than 90% of the infections in the low and middle income countries and more than 65% being in sub-Saharan Africa, as shown on this slide. A couple of years ago, at the International AIDS Conference in Washington, when we began to first speak of an AIDS-free generation possibility and the thought of perhaps a world without AIDS, I spoke about the fundamental, basic, and clinical research, how that was the foundation for the development of interventions in the form of treatment and prevention, which, when implemented by a number of agencies, a number of components, particularly for the PEPFAR program, allowed us to be able to at least think feasibly of an AIDS-free generation. And so in this regard, taking from the PEPFAR blueprint the definition of an AIDS-free generation, for those that we try to explain what we're talking about, it's shown here directly from the blueprint. Virtually no children being born with the virus, and those children who become teenagers and adults, they're at a much far less risk of being infected as they would be today under today's circumstances. And if indeed they unfortunately do acquire HIV, they have access to life-saving treatment. Now, the science of HIV/AIDS over the past 3+ decades has been nothing short of breathtaking in its accomplishments. And I could spend a considerable amount of time on each of these. We're going to get back to them, and I'm only going to pick out one or two. Before we do go to that, let me just mention that we certainly do still have remaining challenges in the arena of discovery, particularly with regard to a cure and a vaccine. But I will not speak about them now. I'll talk about what we already have, the proof of efficacy, and how we can translate that into effectiveness by the implementation program. Let's look at the most dramatic of these accomplishments in the arena of treatment, and how fundamental basic science has opened up the door to transforming therapies for HIV-infected individuals. It started off with the identification of the virus and the meticulous work that went into the delineation of the HIV replication cycle, from the initial binding, fusion, entry, reverse transcription, integration, and finally budding of the virus off in the replication cycle. Each of these provided a vulnerable target for what we now commonly refer to as targeted antiretroviral therapy, which, as a matter of fact, gave birth to antiviral targeted therapy for many other viruses, including hepatitis C. With these advances, we now have a large number more than 30 approved drugs by multiple regulatory agencies. On this slide, showing the US FDA approved drugs, which when used in combinations, now available sometimes with one pill, can actually transform the lives of HIV-infected individuals. A number of studies are testimony to that. This is just one recent one from December of 2013, which essentially says if a person in their 20s comes in recently infected with HIV and go on the regimen that I just described, you can predict to them that they would likely live into their early 70s, essentially more than a 50-year lifespan, compared to when I and many of my colleagues were taking care of HIV-infected individuals in the early 80s before they were drugs, that the median survival when the patients came in with advanced disease was a terrible 6 to 8 months. This is truly an extraordinary transformation in therapy. It's not only confined to the developed world, as shown on this slide with the United States and Canada, but if you look, for example, at cohort analyses from Uganda, in which more than 20,000 patients who initiated HART, the treatment with HART was able to give the projection of an increased life expectancy to nearly normal levels. And we're seeing that in a number of other countries of low and middle income status. If you switch over now to prevention and look at the multiple preventions which are used now in combination, since we know that prevention for HIV cannot only be unidimensional, we started off with rather low-tech approaches, such as behavior modification, the use of condom, needle and syringe exchanges. But as the years went by, medical interventions came about, and I'm going to talk about a few of them. But some of them that are so important are things like prevention of mother-to-child transmission, medical male circumcision, microbicides, and the important treatment as prevention, among others. So let's take a look at some of these. The seminal study back in the mid-90s of reduction of mother-to-child transmission, and this was primitive in some respects because it treated the mother with a single drug and the baby following birth, was a dramatic diminution in the transmission. As we'll get to in a moment, we know now that with aggressive treatment of the mother that we can actually dramatically reduce the transmission to the baby. 3 studies done in South Africa, Kenya, and Uganda on medically supervised male circumcision have led to stunningly positive results. The mechanism for that was the fact that removal of the foreskin essentially eliminated a site of acquisition not only of HIV, but also an important milieu for other sexually transmitted infections. The male to male HIV transmission was decreased, as I shown, by more than 60%. The men's risk of acquiring other sexually transmitted infections such as herpes, syphilis, and HPV was reduced, and it lowered the female partner's risk of cervical cancer as well as bacterial vaginosis. As time has gone by, surprisingly, because interventions that are prevention generally get somewhat less effective as time goes by, with adult medically supervised male circumcision over a period of time as measured here in Rakai, the effectiveness has actually gotten better, gone from 60% to more than 70%. If you look in the field as whether or not if you scale up circumcision from essentially none to about 50+% in a region here in Orange Farm Township in South Africa, the HIV incidence was reduced in that community by 60%, and I'll show you how that actually even gets better. Pre-exposure prophylaxis, a number of studies were done shown on this slide, the first being the IPREX study among men who have sex with men. As shown here, the intent to treat efficacy was 44%. I'll show you how that can be much better. And as you can see, depending on the study, some of the efficacies get a bit better, such as with discordant couples, whereas others are really very poor, such as among women in certain of the studies. We'll get back to the importance of behavior and adherence in just a moment. The prevention of HIV infection by treatment as prevention started with the famous 052 trial in serodiscordant couples, which showed more than 95% reduction when you treat the infected individual earlier rather than later. This is a seminal study whose impact is being felt more and more. In fact, a follow-up study called a partner study, which is in its first 2 years, showed an extraordinary no HIV transmission when the viral load is made undetectable by treating the infected individual in a serodiscordant couple. That is extraordinary results in 75 sites in 14 European countries. So those are the good news about efficacy. So how do we then make efficacy become effectiveness at the grassroots level? And that is what's called the passing of the baton of scientific advances to implementation. And the implementation is towards an AIDS-free generation. And for the next few minutes, I want to talk about the critical role of PEPFAR in making that a reality. You all know and likely have heard at this meeting of the extraordinary impact of PEPFAR. If you look at some selective results in fiscal year 2013, as I showed you a bit ago, 6.7 million men, women, and children worldwide receiving antiretroviral, 240,000 infections averted, testing and counseling for more than 50 million people, 17 million people receiving care and support, and more than 5 million orphans and vulnerable children among them, and 4.2 million voluntary male medical circumcision. Extraordinary accomplishments. Let's take a look at some of these and how they've evolved over the years. We don't have the final number for 2013 for the total number of people receiving antiretrovirals in low and middle income countries, but take a look at the red bars, which represents the increase up to 6.7 million under the PEPFAR program. Through the PEPFAR program, Secretary Kerry, at the celebration of the 10th anniversary of PEPFAR, indicated an extraordinary accomplishment that 1 million babies were born HIV-free during the PEPFAR-supported program. If you look at the number of infections that were reduced in countries that more rapidly scaled up ART, a country-by-country delineation of treatment as prevention, in the red is the slowest scale-up, and in the blue bars are the countries that scaled up rapidly to greater than 60% coverage. Again, an extraordinary accomplishment. If you look at that a different way and go to a region and take a look at when you scale up treatment, what happens to the acquisition of HIV? So if you look at KwaZulu-Natal in South Africa, you had a coverage that was from less than 10% to up to 30 to 40%, which led to about a 38% lower risk of acquisition. And in British Columbia, when you increase coverage from 11 to 57%, the incidence fell by 42%, which brings up the much discussed issue of tipping points. Now, a tipping point, as we know, is when the number of individuals starting antiretroviral therapy is greater than the number of new infections. And as you see on the lower left, it's when those lines cross that we call it a tipping point. And already 13 low and middle income countries have reached this very important tipping point. And so with that, we've now seen about a 30% decrease in deaths on that slide where I showed you the broad epi. And that has occurred since 2005. And new infections have gone down by 33%. However, as I say often, it is the truth, there still is much to be done despite the fact that much has been accomplished. And let's just take a very quick look at some of that. I spoke about the decline in incidence and just showed you the percentage data, but we need a much steeper decline. That is important, as you see on the slide. It needs to go down much more. If you look at the number of new infections among children, again, the curve is going down, but we still have a way to go to reach the the 2015 target. In fact, if you translate that into numbers, despite the extraordinary progress in the prevention of mother-to-child transmission, and despite the fact that I showed you that under the PEPFAR program, 1 million babies were born HIV-free that would not have been born HIV-free, there were still, sadly, 260,000 infections globally that were acquired in 2012 among infants. We know of the option BB plus and the recommendations now of all pregnant and breastfeeding women with HIV should initiate triple therapy with antiretroviral drugs. Clearly, if we implement this well, we will reach the point in our program, in the global program, where we in fact have no babies born HIV infected. I know that's a lofty aspirational goal, but it's possible. Let's turn over now to pre-exposure prophylaxis. I showed you the somewhat disappointing data, mostly due to poor adherence. If you look at individuals where there's general adherence that is not that good, you have that low 44% or less number. But in a recent study in East Africa, in which you had serodiscordant couples, in which it was clear that these people clearly took their medication, that it was a greater than 90% efficacy. So in its proper situation, with good adherence, pre-exposure prophylaxis works. It tells us the importance of interdigitating biomedical interventions with appreciation of the importance of human behavior. But we're going to go a step further because there's medical interventions that could help, and that is work that's going on now in testing long-acting HIV, anti-HIV drugs, in this case long-acting integrase inhibitors, in a macaque model which showed extraordinary efficacy in shots that could last several months. And that could be an important complementing the adherence problem and getting people to take their medication more regularly, albeit intermittently. Let's take a look now at getting people on ART. The goal and target of 15 million people by 2015, we still need to get there, and it's a rather ambitious target. Now, this is an interesting slide because if you look at the blue slice of the pie, those are the number of people that are on receiving antiretroviral therapy at the end of 2012. But if you look at the most recent and latest WHO guidelines on 2013, look at the number of people that were eligible who were not yet receiving antiretroviral therapy. So we still have a long way to go to get the people who need to be on therapy on therapy. The same holds true for circumcision. Despite 6 million circumcisions for HIV in Southern and Eastern Africa, we are only 1/3 of the way to the goal of more than 20 million circumcisions by the end of 2016. Now, Mark Dybel, Peter Piot, Jones, and others in a recent Lancet paper have put forth the concept of hot zones, namely concentrating on those high transmission geographies and populations, and to provide tailored packages of intervention. This is something that needs to be seriously pursued. And so over the last several minutes, I've told you about what's been accomplished, but hopefully I've gotten my message across that much needs to be done. And as said in a recent paper at the end of last year, that the end of the HIV/AIDS pandemic is a feasible goal. However, there is still much to do, and now is not the time at all for a victory lap, but the time for racing ahead. So, said another way, PEPFAR's job is just not completed if we are to get to our goal. And so, ladies and gentlemen, I want to thank you again for the opportunity to talk a bit about how we got to where we were with a scientific base, and how by implementation of the interventions that have been the result of these scientific answers, that we may in fact be able to see within our reasonable period of time, through the work of PEPFAR and other organizations, truly an AIDS-free generation. Thank you very much.